Hello and welcome to another intensivcarehotline.com and intensivecareathome.com emergency questions and answers for families in ICU and for families with intensive care at home. I want to welcome you to this live stream, and I also want to welcome you if you are watching this on replay. So this session today is about answering your questions, and it is about getting your questions answered. Before we dive into today's questions, please type your questions into the chat pad or join me live on the StreamYard link here. And you can join me live on the StreamYard link by clicking on the link that I just share here. There we go. What makes me qualified to answer questions for families in intensive care and for families with intensive care at home, or for patients with intensive care at home? I'm a critical care nurse by background. I have been working in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently and without any exaggeration say that we have saved many lives with our consulting and advocacy here at intensivecarehotline.com. And you can verify that by checking out our testimonial section at intensivecarehotline.com, or by listening to our intensivecarehotline.com podcast, where we have some client interviews verifying the work that we have done. With intensive care at home, I am the founder and managing director, just as I'm the founder and managing director of intensivecarehotline.com. And with intensive care at home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also otherwise medically complex clients on BiPAP, CPAP ventilation at home, tracheostomy care at home without ventilation, home TPN, home IV magnesium, home IV potassium infusions, as well as palliative care. We're also sending our critical care nurses into the home to prevent emergency department admissions, and we're basically providing an emergency department bypass service. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TAC WorkSafe in Victoria, iCare in New South Wales, and IISQ in Queensland. We are also DVA approved all around the country. We're also providing level 2 and level 3 NDIS support coordination. Right, and our respective websites are intensivecarehotline.com and intensivecareathome.com. Without further ado, let's dive into today's questions. And the first question or email is coming from Sarah, who says, "Hi Patrick, my dad was brought into intensive care on last Monday after having an epilepsy seizure whilst in a canal boat and fell into the water. He was still seizing after they removed him from the water fairly quickly, as he had no evidence of drowning in his lungs, but his heart stopped but was started again, and then he was transported to the hospital. They immediately didn't think it was positive and told us to say goodbye. However, after being put into an induced coma, he became stable whilst we were there on the 4th. Then on the 5th, his vitals recovered. He contracted pneumonia, but a day or so later, his lungs looked normal, apparently. They reduced his sedation the morning of the 5th, but he started fitting, and so they felt it was best to re-sedate him. The following morning, they reduced sedation. However, I felt he was still fitting, as he was twitching in his face. They didn't seem to do anything about it until the following day. They gave him stronger medication for it. We were told again, doom and gloom, he won't make it as he hasn't woken up yet. This was on the 5th as well. On the 6th, he started yawning and having small facial expressions, but nothing consistent, and opening one eye, but again not consistently. We get to Saturday and they said they did an EEG a few days before and CT, and were going to give results, but EEG that was clouded by the seizures. CT showed apparently a normal brain, and they were lost to understand. We had no questions to ask. We didn't know what to ask. And I say, of course, you didn't know what to ask, because intensive care is such a highly specialized area that you wouldn't have a clue what to ask unless you've worked in the space for decades like I have. Now it's Monday and they have reviewed the images again and have said he's unlikely to have any recovery or quality of life. They said that if he has a heart attack or has anything occurring between now and when we go in tomorrow, they won't be resuscitating him. My question is that, should we be asking how can the same scan change? Are they allowed to just say it's over and pull the plug? We are lost with what to even ask. Many thanks for your website. I'm so glad I found it, from Sarah. Well, Sarah, thank you so much for writing in that much detail. So your dad obviously might have a history of seizures if he's had an epilepsy seizure, and if they removed him from the ward, there's a high chance he had a cardiac arrest. Even though they restarted him, the question is, how long was he underwater? How much brain damage has there been done? If the brain is without oxygen for more than 3 minutes, the chances of sustaining irreversible brain damage is very, very high, right? So with ICU saying you should say your goodbye after only a few hours, that is what they normally do to create this doom and gloom and negative narrative. Don't buy into it, right? Do not buy into it. So what you should be doing in a situation like that, always do your own research, create your own narrative, right? ICUs don't want patients in ICU for too long, right? By giving you the doom and gloom narrative, by telling you, hey, I've got to, your dad is dying and so forth, with that doom and gloom narrative, it makes it easy for them to say, well, look, we told you so, your dad is dying. Imagine they would be telling you, well, we'll treat your dad for 3 weeks, whatever, and then he'll walk out of ICU alive, and it's not happening. You could potentially hold them to account and sue them. So then you're saying, the lungs look normal. Apparently that might have been because they were ventilating him. Maybe they gave him antibiotics to clear the pneumonia, right? Then they was reducing the sedation on the morning of the 5th, but he started fitting. So they felt it was best to resedate him, and then they reduced sedation again, and he was still fitting, and again, they were giving you the doom and gloom spiel. But what I can see in your dad's situation, after having worked in intensive care for nearly 25 years, it's very early days. And you're trying to look for answers, for quick answers. And the reality is there won't be any quick answers. Only time will tell you what's going to happen here over time, right? Only time will tell you what's going to happen here, right? And because he's got a history of seizures and he's probably still sedated, he's on anti-seizure medications, it might just take him a while to wake up. And the reality also is he may never wake up, or he may not wake up to the extent that you would like him to wake up. And he may not wake up to the degree where, you would be happy with his quality of life, or where he would be happy with his future quality of life. But again, quality of life is a perception, it's a subjective measure. And you have to, ascertain what quality of life is acceptable for you and your family. What quality of life would be acceptable for your dad if he survives this episode, right? Also, another question that often comes in here is, what is a meaningful recovery? What might be meaningful for you might not be meaningful for the ICU team. But that should not concern you. This is about you and your family, right? It's not about anything else. Now, you're saying it's Monday and they've reviewed the images again and have said he's unlikely to have any recovery or quality of life. They said that if he has a heart attack and has anything occurring between now and when we go in tomorrow, they won't be resuscitating him. Well, they basically tell you that he's not for resuscitation. He's basically NFR/DNR. Well, they can't do that without your consent. If he was to die between now and, and you haven't given consent, that could be perceived as murder, right? So you have to think about these things in terms of your rights. At the moment, you think you don't have any, but you also haven't approached this situation with common sense. You need to approach this situation with common sense, right? And if you're not approaching this with common sense and logic, you will be on a downward spiral here. Think about it. Can ICU teams just withhold care and treatment and not resuscitate? Once again, that could be perceived as murder, right? Use common sense and logic. You're also asking, my question is, what should we be asking? How can the same scan change? Are they allowed to just say it's over and pull the plug? Well, of course not. Again, imagine ICU teams would be pulling the plug without consent. Once again, that could be perceived as murder. Once again, please use common sense and logic. What questions should you be asking? Questions you should be asking for: what are ventilation settings? What medications is he on? What are blood results? Get the CT scan reports, get the MRI scan reports, get the EEG report, right? And then let us look at the medical records. Let us look at everything. You know, you need a second opinion in a situation like that, or you need to let me to talk to doctors and nurses directly and ask all the questions that they can't avoid, right? You're saying, what questions should you be asking? Yes, I can understand you don't know what questions to ask right now, because it is very difficult for you to know what to ask in a situation like that, because you haven't seen it before. You don't understand the complexity of it. It's like piecing together a puzzle when you have a loved one critically ill in intensive care, right? And I can understand that you're lost to even know what to ask for. I can totally understand that, because it is such a complex situation, right? So I hope that helps Sarah to know where you need to go with this next. But you need to have time. You need to give this time. You know, your dad waking up is like switching on a light with a dimmer, not like switching on a light with a switch. That is what it comes down to, right? So if you have any questions, please type them into the chat pad or join me live on the show here. And you can talk to me directly here, or just type your questions in the chat pad. You know, you can go on camera with me here. You can just talk to me without going on camera. It's up to you, but you can also type your questions into the chat pad. That's why I'm running these shows, so that I can answer your questions directly. If there are no questions, I've got plenty of questions here in my email inbox that I will read out. And the next question comes from Rhea, who says, it's a bit of an odd email. Rhea says, hi, Patrick. I had an experience that was very difficult. I was caring for my mother who had Alzheimer's, and since we managed to move closer to New York City, I was able to take her to multiple hospitals, and many just gave me a look like there was nothing. That can be done for the evolving loss of function. But I kept hoping and investing in nutrition and vitamins. But once her sudden shudder attacks with her arms extended, I had a private ambulance drive us to a top emergency hospital. I had asked for a stomach feeding tube so I can return home with her continued care. I refused as per her request a catheter in her private area, and refused their request for a needle to be put in her back because they said she had full pleural effusions in the left lung. They probably would have wanted to drain the pleural effusions. I thought that was her favorite side to sleep, so they must have seen something different. The doctor, without my consent, moved her into hospice. I told them I wanted to transfer to for another opinion, because of all the hospitals we had visited, none had ever mentioned this to me. So she has had x-rays done in the past. But he said she had lung cancer and that they want her home with me. So I walked out to her room, and not having any suspicion, I saw a nurse inject her IV, and I thought they were sedating her for the ride back home. When I began to call medical supply stores for a medical bed, they called me and they said she had passed away. I was destroyed and unsure as to what happened. She passed the swallowing test, so they refused to place the feeding tube for her to regain strength. I need to read that again. She passed the swallowing test, so they refused to place the feeding tube for her to regain strength. I was wounded and in deep grief, not ever expecting she all of things had lung cancer. Maybe she self-sabotaged her health by over-smoking. When she realized she had developed what her mother had when she was in her late 20s, but my pain has not gone in the past 10 years, because I wonder if we were trusting enough to take such an action, or were they covering up an error on their part? I developed permanent sadness I haven't been able to shake off. But if you tell me that hospitals are in a position to make such decisions, even if I was not fully aware, maybe it can help me move on. Thank you. Always learn so much in receiving your emails. From Rhea. Rhea, thank you so much for writing, and I'm very sorry to hear what you've gone through. And it sounds to me like that's 10 years ago, but you are obviously you still haven't come to terms with what was happening, right? So it's interesting to understand, that you think a withdrawal of treatment has taken place without your consent. Can the hospitals do that? No, they can't, unless you let them and you're not holding them to account, right? Which is what it looks like to me has happened here. You were going in with your eyes blind, like 99% of families in intensive care. They're going into those situations with their eyes blind, and they don't understand what's happening, right? And this is exactly what's happened in your situation. You do not understand what's happening here, or you didn't understand what was happening. You didn't know about your rights, right? The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And once again, that is exactly what you are dealing with here, right? So how come you are, how come you did go in this situation with your eyes blind, right? Similar to Sarah's email earlier, you didn't know what you didn't know, and it cost your loved one's life, most likely, right? And I argue from what you're sharing with me, that might have been murder, right? Moving your mother to hospice without your consent, without your mother's consent. What else would it be? What else would it be? Moving someone to hospice for end of life, removing all life supportive measures, letting your mom die. What else would it be? For any of you watching this, leave a comment what you think it is. I think it could be perceived as murder. Leave in your comments what you think it is. So, but it goes to show, once again, you cannot afford getting a once-in-a-lifetime situation like this wrong. You just can't, right? If you are getting it wrong, your loved one might die. Just what's happened here in Rhea's situation, right? Like I said, I can very confidently say we have saved many lives with intensivecarehotline.com, and you can verify that on our testimonial section at intensivecarehotline.com, or you can verify it on our intensivecarehotline.com podcast, where we've done client interviews, right? So you need to take responsibility as well. You can't just go into those situations blind, right? If you have a loved one in intensive care, you're going in there blind, it is your own fault. You need to take responsibility, right? You can't go into those situations blind, right? We can do a medical record review now, Rhea, but it's probably too late. For you to make a claim needs to happen within a few months. So you must have been extremely naive going into this situation, extremely naive. I'm sorry to be so blunt, but that's just the reality of it. That is just the reality of it. So it's very important that when you have a loved one critically ill in intensive care, that you take 100% responsibility for everything that's happening, right? Okay, so for any of you live on this show, type your questions into the chat pad, or join me live on the StreamYard link here. Do that, and you can talk to me directly. You know, if there are no questions, I will move on to the next question that was sent to me via email. There are so many of them. So the next question is from Loretta, who says, "Hi, Patrick. My brother-in-law nodded yes when asked if he wanted some ice cream today. Again, he's in a medically induced coma for being septic, and they have been lowering medications to try to bring him out of his coma slowly, and also are having a tracheostomy to be scheduled. Do you think that this is necessary to tracheostomy? Can you give me your personal opinion on what you think about the situation right now that I just told you about?" Sure. Thank you, Loretta, for writing in. Once again, I am repeating myself here, and I do feel like sounding like a broken record. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. In order to ascertain whether your brother-in-law needs a tracheostomy or not, the following things I would need to know. How many days has your brother-in-law been in intensive care for, and how many days has he been ventilated for? That would be one of the most important questions. Is he still in an induced coma? Is he still on sedatives and opiates? Right? And you're saying they're trying to lower his medications, but what medications? Right? Next, what are the ventilator settings? Right? Is he already breathing spontaneously? Because if he is, then the chances of him not needing a tracheostomy are much higher. Right? Next, what are his arterial blood gases like? Right? Next, what are his chest x-rays like? Right? Has he had any spontaneous breathing trials? Has he been mobilized? Is he still on sedatives and opiates? Right? So, you know, the devil is in the detail here. People don't understand that when you have a loved one critically ill in intensive care, that the devil is in the detail. Right? And if you don't understand that, you'll be fighting an uphill battle. If you don't understand that you have rights, but you need to exercise them, you will fight an uphill battle. Right? If you don't understand that, you know, needing a tracheostomy or not is all on that it depends on a number of factors. Right? Unfortunately, it's not black and white often. You know. Okay. So that was the question from Loretta. Now let me move on to the next question. Unless if you have a question, type it into the chat pad or join me live on the StreamYard link that I posted into the chat pad. So you can join me here live on the show and talk to me directly. Let's move on to the next question that's been coming in this week. And the next question comes from Sylvia. Sylvia writes, "Hi Patrick, I desperately need your help. My 86-year-old father had surgery to remove his kidneys due to cancer. The cancer was localized to the kidney. It had not spread, and they were able to get all of it out. My father did well with the surgery, and the doctor was planning on discharging him in a few days. However, 2 days after the surgery, he developed pneumonia. He was intubated for 3 weeks. He was not able to be extubated, and they performed a tracheostomy. Now, almost 6 months later, he's still hospitalized in the ICU, unable to get off the ventilator. Our family is under so much stress. We have suffered from both physical and psychological distress. We don't know what to do to help our father. Recently, he has shown some minor improvements. They placed a pigtail catheter in his lungs because they were constantly filling up with fluids. However, they have not removed any fluids from his left lung in 2 weeks and very little from his right. However, although he makes urine, they have started dialysis 3 times a week because his creatinine is high. We want our father taken off the ventilator. However, when they do the breathing trials and place him on CPAP, his respiration becomes too high and they discontinue the trial. Either his respiration becomes too high or he develops a bacteria and is not able to do the breathing trials. This is the hardest thing our family has gone through. We are very close. We are a very close family, and we are devastated to see our father and our mother, her beloved husband, lying in a hospital bed for nearly 6 months, not knowing how to help him. It is so frustrating. Our mother cries herself to sleep each night. She misses him so much. Prior to the surgery, my father was mobile, went on walks every day, and now he's lying in a hospital bed. Please help us. From Sylvia. Well, Sylvia, thank you so much for sharing your dad's situation with me. This is obviously a very difficult situation, and I can understand that you don't know what to do next now, but I can tell you that the best next step here is to get him home with intensive care at home. That is your best next option here, right? Quite simply, if he's failing the breathing trials and if he's failing to go home, or if he's failing the breathing trials, if he's still on dialysis, if his respiration becomes too high, clearly something's not working, and he'll be much better off at home, because at home patients, unlike in a hospital, have quality of life, so and especially since you are a close family, you will be much better at home, but much better off at home with intensive care at home, right? So once again, that's a no-brainer to look into that. So what do I mean by that? So you may not have heard of an option like intensive care at home. Intensive care at home brings the intensive care into your home, as I suggest here. What that means is, we are sending intensive care nurses into the home 24 hours a day that are ventilation and tracheostomy competent, right? And that's an easy fix, and before you probably ask me who's going to pay for it. Well, someone is paying for the ICU bed right now, and the ICU bed costs $5,000 to $6,000 per bed day, right? If an ICU bed costs $5,000 to $6,000 per bed day, intensive care at home is about 50% of that, right? So whoever's paying for the ICU bed now will have an interest to pay significantly less, whilst giving your dad quality of life, or maybe quality of end of life, depending on what is exactly going on, right? If he can't come off the ventilator, and giving you and your family quality of life because you're spending day and night in hospital, right? So it is a no-brainer with intensive care at home, and for the ICU, what's in it for them? They want an empty ICU bed, right? It's a win-win situation all around, right? The other thing is, is your dad getting mobilized? If his respiration becomes too high and they discontinue the trial, is he getting mobilized? Are they strengthening his breathing muscles? If they're not strengthening his breathing muscles, he'll have a hard time getting off that ventilator, right? But we can do all of that at home, and again, especially since you are a close family, he'll be much better off at home. So I encourage you to check out intensivecareathome.com, and you can call us there on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. Okay, so moving on to the next question. in a minute, or if you have any questions, type them into the chat pad or join me live on the StreamYard link here. But Sylvia, you know, there's definitely help at hand. You know, you should not be in hospital for 6 months. You should not be in hospital for 6 months. You know, far too long. But I'm glad you know now what your next steps are. You know, I'm glad you know what your next steps are. Okay, so let's move on to the next question. If you have any questions, please type them into the chat pad or join me live on the StreamYard link here that I posted there. And the next question is from Annette. Annette says, "Hi Patrick, I wonder if you can give me some advice. My husband has had a brain stem stroke. He has been improving slowly. However, he was placed in a nursing home. He had been there for 17 days. He developed a collapsed lung and chest infection. He was admitted to the hospital in April and the chest had been treated. He had several infections while in hospital. He also is PEG fed and there seems to be an issue with the PEG feeding. He was not keeping the feeds down. So they put the PEG tube further down on the lower bowel, which is also known as a PEG tube, which he seems to be tolerating the feeds now. He is now ready to go back to the home. The doctor of the home says he will not accept him back unless the family signs a peace document stating he is not to be admitted to hospital should he become unwell. We as a family have not agreed to sign this because everyone needs to be treated if they are unwell. We as a family, the family have agreed to palliative care because they say he has long-term medical issues and agreed to treat him at home first should he become unwell before going to hospital. He also has a tracheostomy. I feel we are being pressured into signing this peace document. I don't believe anyone should be pressured into doing this. Am I right on saying so? I would appreciate your advice." From Annette. Well, thank you, Annette, for writing in. Okay, quite frankly, similar to the previous email with Sylvia, one option here for you is intensive care at home. Quite clearly, you know, obviously he's got a PEG tube now. He probably still has a PEG for maybe for medications. You know, there's you can have a PEG and a PEG, right? For feeding and for medications, and he's got a tracheostomy, right? And you will find that with your dad going home, you will find that he'll be much better off at home, even if it is for palliative care, right? But you will also find that your dad, I argue, will improve at home, right? So patients are recovering much better in their own home than they do in hospitals, in ICU in particular, right? In terms of your dad, you know, the hospital saying he should not be readmitted back to hospital in case he deteriorates at home. I strongly disagree with that, of course, because like you say, everyone should be treated if they are not improving. However, here's another important thing. Another important thing is with intensive care at home, our clients don't go back to hospital. They just don't, right? Because we keep them at home predictably with 24-hour critical care nurses, right? So, no-brainer. And similar to Sylvia's email earlier, you know, by delivering intensive care at home, you know, the cost of an ICU bed is being cut by 50%, right? And the ICU will have an empty bed, and your dad will improve his quality of life. Your husband will improve his quality of life, and you will improve your quality of life. Your family will improve their quality of life, right? So I would not sign anything but work on getting him home with intensive care at home. That's what I would work on if I was you, right? just focus on the right things here. And once again, use common sense. No one can force you for palliative care, right? And just get an advanced care plan for your husband so that it's documented what you want for him. That is really important. You know, you need to document what you want for your husband, right? So just once again, please use common sense. Use common sense. And talk to us. Go to intensivecareathome.com and call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com so we can help you with setting up home care. You know, once again, common sense. I hope that answers your questions, Annette. Now, before we move on to the next question, if you have any questions, please type them into the chat pad, or, you know, join me live on the StreamYard link here. Join me live on the StreamYard link. And talk to me here directly. Don't be shy, I don't bite. All right, so let's move on to the next question. From Josie, who says, "Hi Patrick, a few days ago my father had an ischemic stroke that turned into a hemorrhagic stroke. For the first day or two, he was aware a little, though he couldn't speak or understand. Since I've been able to visit him, he has been asleep the whole time, unable to open his eyes or respond. He had some seizures that required him to be sedated and put on a ventilator, which wasn't originally needed. He has a feeding tube in the nose as well. He's in ICU and has been since the stroke. The other day before the sedation, he did open his eyes once or twice. Apparently, when my stepmom visited him, he was able to mumble to her little, 'I love you.' He was able to smile, but I haven't seen a thing of that in the last 3 days. He has a clot in his heart apparently as well. That may have been the cause of the stroke in the first place, since it wasn't pumping blood to the brain properly. He has a clot in his heart apparently as well. That may have been the cause of the stroke. Yeah, that is very likely that was the cause of the stroke. I'm his 18-year-old daughter. I am so worried to my core, because I'm so young and cannot lose my dad. The nurse said something that deeply concerned me, that there's a greater possibility that he won't wake up properly than not. But according to my stepmom, they're supposed to give bad news before good news. Since he was awake before, please can you tell me what you think will happen to him?" From Josie. Well, thank you, Josie, for writing in. I'm very sorry to hear about your dad's situation. Well, it's only a couple of days, right? You have to be patient here. You have to be absolutely patient here, right? 2 days in ICU is not a long time. Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. And once again, that is exactly what you are dealing with here, Josie, right? So 2 days in ICU after an ischemic stroke, not a long time, right? 2 weeks in ICU after an ischemic stroke, probably not a long time either, depending on the exact circumstances. He's a typical ICU patient now. He's got a feeding tube, he's ventilated, right? He's opening his eyes, but, you know, he's trying to mouth words. So what should be happening here next? Wake him up, get rid of sedation, get rid of opiates, try to wake him up, and try to wake him up and see what he's doing, how his brain is responding. Can he move his arms? Can he move his legs? Right? So that's what needs to happen here. Right? So, and in the next few days or weeks, you will see what's going to happen. Right? You will need to give this some time. And I know that's deeply distressing for you and your family, but once again, recovery in ICU is probably more like switching on a light with a switch rather than switching on a light, it's like switching on a light with a dimmer rather than switching on a light with a switch, right? So you got to give this some time, got to be patient and see what happens next. Ideally, you can avoid a tracheostomy, but what can happen after a stroke is that patients have swallowing difficulties, right? And if patients have swallowing difficulties, right, they might need a tracheostomy. They might be able to get off the ventilator, but they still might need a tracheostomy. Okay, but also, have they done an MRI scan of the brain, a CT scan of the brain? Have you spoken to a neurologist, right? Those are all questions you should be asking for. Also, get access to the medical records. Get access to the medical records so that you can get a second opinion through us. We can look at the medical records, right? And again, if all fails, if he needs a tracheostomy, if he can't be weaning off the ventilator, if he can't wean off the ventilator or needs a tracheostomy, even though he can be weaned off the ventilator, then look at options such as intensive care at home, right? So patience is the name of the game here. Okay, so next question. And if you have any questions, please type them into the chat pad or join me live on the StreamYard link. I've posted the StreamYard link in there. If not, I will have more questions to come. Got plenty of emails sitting here, but it's a good opportunity for you to ask your question here live on the show. Type them in the chat pad or join me live on the StreamYard link here. Now, next question is from can't see a name. Christy says, hi Patrick. My mother is diagnosed with COPD and required use of an oxygen machine at home. She had complained and began panicking from not being able to catch her breath 3 days ago, and she's now on a ventilator in the hospital. She was admitted for extreme shortness of breath. O2 sats was in the 50s. They sedated her and placed her on a ventilator. 3 days later, the doctor expressed there's no other options, placed her on hospice and are doping her up with sedatives and propofol and morphine until she dies from organ failure. Is there really nothing else we can do? Please help us ASAP before they kill my mom. I need to know we did all we could do for her. Well, that is very sad, Christy, to hear what's happening here, but similar to some other emails that I've answered on this call before, that is murder. Murder or euthanasia, right? I don't know the ins and outs of your mother's situation. She might have COPD. I don't know whether it's end-stage COPD, but placing her on morphine, midazolam, and the like, that will hasten death, and that could be perceived as euthanasia, right? So what can you do? Put a stop to it. Put a stop to it. That's what you should be doing. You have rights. They can't just take your mom's life away without trying, right? That could be perceived as murder or euthanasia. Very simple. And, murder or euthanasia are both illegal, right? Use common sense and logic. Use common sense and logic. It's very important. I actually can't believe that, but I can't believe it's not what they do. It's not what happens to you. It's how you respond, right? And if you respond with apathy and you think you have no rights, then that is your own responsibility. If I was you, I would jump up and down. I would make some noise here. And I would hire my service because we have saved so many lives for families in intensive care. Again, you can look that up on our testimonial section. I'm happy to talk to doctors and nurses directly. And I've talked to so many doctors and nurses over the years where I say, well, if you keep doing that, that's murder or euthanasia, and they stop. Right? It's common sense. It's common sense. So you need to take responsibility here for what's happening and for what you're doing. you need to take responsibility. Right. Okay. So now, got a question here from Nada, who's live on the show here. Nada says, hi, Patrick, I asked you a question a couple of weeks ago. My aunt is still without tracheostomy. They say she has high white blood cells. The night before planned the procedure, she got a fever. I want to ask what can cause severe head pain and then seizure-like activity when someone is on a ventilator. This is what happened and what led them to put her on propofol. She was having slow contractions like movements, and instead of trying to find the cause, they only increased sedatives. Okay. I can't remember Nada to talk to you, but that's okay. I do not. I am honest here. But I'm talking to so many people every week. That's probably why. If she's having a high white cell count, she's having an infection, which makes it more difficult to do a tracheostomy, because you can't really do a tracheostomy if someone's having a severe infection. You know, that could be dangerous. If she's got head and seizures, like when someone is on a ventilator, they wouldn't know what's causing that unless they're doing a CT scan or MRI scan, EEG, and get a neurology review. Right? Very, very simple. They need to do a neurology review. Right? So that's how they can find out why she's seizing. Yeah, only increasing sedatives without investigating is not good enough. It's simply not good enough. You know, depending on who you ask, nurses, doctors, we are told it's normal, it's from pain, it's seizures, even though they never did a brain scan. Having seizures is not normal, definitely not. They say they can't do that. Why can't they do a CT scan of the brain? I can tell you if they can't do it because they don't have a CT scan machine, then she's not in the right hospital. Then she's not in the right hospital. Right? So I think there's a number of issues here. Number of issues, Nada. You know. So I hope that answers your question, Nada. It might be easier if you join me live on the call here. I'll just post the StreamYard link again to nod out the questions that you have. In the meantime, I will get on with the next question from G. G says, hi, Patrick. I would like to get some help with my 89-year-old dad. He was supposed to discharge last Sunday, and the moment we moved him to the car, still at the hospital lobby, he suddenly collapsed. We then immediately rushed him to the emergency department. They did CPR for him and got his heart back after 26 minutes, and he was under sedation and he got intubated. He has been coughing and had an aspiration pneumonia the first time he was admitted. Lots of phlegm, and we are still not sure the reason why he collapsed. He had multiple strokes previously, and the last one happened last Christmas and caused his right hand and leg not to move. He also had dementia and Parkinson's. The throat is not sensitive, always chokes on liquid, but still able to take porridge before he got admitted. Now, back to now, he's intubated for a week. Sedation was off for 6 days. So far has not woken up. He's having some self-breathing, PEEP at 10, and breathing can go up till 24 or 25 breaths per minute. However, just last night, they tried to have a CT scan for him. Not sure what happened after that. The expiratory rate decreased. The doctors did a new round of intubations for him, saying that the tube connections was not good and caused an air leak. They sedated him a bit again. Now the PEEP is on 10 and ventilator number is 14. His kidney creatinine is increasing every day, now up to 320 from day 170. He's got an enlarged heart. The doctor said we can keep him as far as we want, but also worry the complications that may happen along the way. The tracheostomy is mentioned, as well as end of life. My family decided to keep him in hospital till the very last minute. We are very worried and scared. Some questions. Can they extubate him if he can self-breathe? As I search, saying the ventilator too long may cause kidney failure as well. My dad's body is swelling. Do we need to be patient, to be conscious before extubating him? Doctor also worries his airway got stuck back if extubation. Doctor is not suggesting dialysis anymore due to his age and very weak heart. What should we do? Can we keep tube ventilator for him without tracheostomy? You can't really keep the tube in without the tracheostomy for too long, right? No more than 2 weeks, right? So you want to keep him in hospital, until the end. You can do that, right? You have the right to do so, right? Especially since you know what he wants, you know what you want. But also, again, in a situation like that, if it comes down to a tracheostomy, similar to other emails we had earlier, you can go home with intensive care at home. Very simple. So very simple to go home with intensive care at home once he has a tracheostomy, but maybe he doesn't need one. It is very early days, right? You're saying PEEP is 10 and ventilator number is 14. What ventilator number? When someone is ventilated, there's 10 different numbers, right? Again, the devil is in the detail here, right? But it's good that you've put all options on the table, whether it's a tracheostomy, whether it's, end of life, it's good that you've put it all on the table. Okay, so Nada, you are saying, thanks, Patrick. I believe they are afraid of contrast effects on the kidneys. I don't know why they don't do the EEG either. You don't need contrast for a CT scan or an MRI scan. You don't. Who says that? Some you do, but not necessarily. That's what I have to say about that. They're probably making excuses. That's what it is. Coming back to the email that I just read out from Jinji. It is, once again, it is very early days. It's only been 6 days. It's only been 6 days. And with an enlarged heart, lots of people have an enlarged heart. That doesn't mean he's not going to survive. It really depends on his ejection fraction, which is the strength of the contractility of the heart, right? So, you've put it all on the table. Tracheostomy is mentioned as well as end of life. Your family decided to keep him in hospital till the very last minute, You can do that, or you can look at intensive care at home. You can also look for palliative care with intensive care at home. That's one doesn't rule out the other. One doesn't rule out the other. So, with all of that said, I am going to wrap this up for today slowly. I have time for a very quick last question. If someone wants to type it into the chat pad, I have time for a very quick last question here. If you have a loved one in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. We also have a membership for families of critically ill patients in intensive care at intensivecarehotline.com. You can join the membership if you go to intensivecarehotline.com, click on the membership link, or go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related in the membership. In the membership, you also have exclusive access to me and my team, and you also have exclusive access to 21 ebooks, 21 videos that I have personally written and recorded. And you will be in a position to make informed decisions, have peace of mind, control, power and influence, making sure your loved one gets best care and treatment. You need to be in a position where you can influence decision-making fast, which is exactly what we do here, right? I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly, and I handhold you through this once-in-a-lifetime situation that you can't afford to get wrong. I also talk to doctors and nurses directly, and I ask all the questions that you haven't even considered asking. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get that crucial second opinion in real time, right? We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. With intensive care at home, we are currently operating all around Australia and all major capital cities, as well as in regional and rural areas. We are NDIS approved service provider in Australia, TAC and WorkSafe approved in Victoria, iCare in New South Wales, and IISQ in Queensland. Furthermore, we are providing level 2 and level 3 NDIS support coordination as well. So if you are on the NDIS and you need a new NDIS support coordinator, or you are not on the NDIS yet and you need help, please contact us. We also do TAC case management. That's what we're offering too. Next, if you're at home already and you need help, right? You're on a ventilator, you've got a tracheostomy, but you don't have enough support, you know, we can put a stop to your hospital readmissions and we can keep you safe. You know, patients have died on ventilation tracheostomy at home if they didn't have the 24-hour critical care nurses, right? And our services are evidence-based. You need 24-hour critical care nurses for anyone at home, ventilation, tracheostomy, BiPAP, CPAP, you know, anything less than that has cost people's lives, and it's evidence-based. Check out the mechanical home ventilation guidelines on our website at intensivecareathome.com. Furthermore, we are the only service in 2024 that has third-party accreditation for intensive care at home. No other service has achieved that, right? And if you're in the US, in the UK, watching this about intensive care at home, we can help you there privately. So please reach out to us privately if you need help with intensive care at home in the US or in the UK. If you are a critical care nurse looking for a career change, we have jobs for intensive care at home in Sydney, Melbourne, Brisbane, as well as in Warragul in Victoria, Bendigo in Victoria, Geelong in Victoria. And you need to have a minimum of 2 years critical care nursing experience, ideally with a postgraduate critical care qualification. And if you're an intensive care specialist and you're looking for a career change, we want to hear from you as well. We can also help you empty your long-term ICU beds with intensive care at home. Same if you're a hospital executive watching this, we can help you emptying your ICU, ED, and respiratory ward beds, especially with long-term patients, and you won't even pay for it. So that's enough for today. I do these YouTube lives every week around the same time, 10:30 a.m. Sydney, Melbourne time on a Sunday, which is currently 8:30 p.m. Eastern time in the US on a Saturday night, 5:30 p.m. Pacific time on a Saturday afternoon in the US. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I'll talk to you during the week. Take care for now.